Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to sign the attendance record, and also I would request that you would fill out the program evaluation, and please give the CME committee any ideas that you might have in regards to future topics or future speakers. Our speaker today is Connie Diekema. Ms. Diekema is a graduate of Drake University, where she received her law degree and subsequently earned a Master's of Health Administration degree from the University of Osteopathic Medicine and Health Sciences. She has extensive experience in litigation involving healthcare professionals and institutions, and has advised clients on a wide range of issues relating to risk management, professional licensing and credentialing, quality assurance, medical records, insurance coverage, and restraint of trade. Connie is a frequent speaker on medical and legal issues, and in fact has previously presented at programs that we have jointly sponsored here with McFarland Clinic. And she's here today to discuss issues related to aging physicians, and please join me in welcoming Connie Diekema.
Okay, it works, great. Good morning, good afternoon, noon straight up. We're going to try and get you in and out today. I'd like to answer your questions, so if any time you think of something, raise your hand, yell it out, whatever, we'll try and go through that. I appreciate the opportunity to speak to you today. When I was asked to speak on this topic, this is a new one for me. I think it is a very relevant topic. I think it's something that we need to talk about, and we'll get to some later slides, and I'll show you kind of what's been going on with the Iowa Board of Medicine, because I think that that's an issue we need to address today. Aging physicians are our best source of information. Wonderful people put their whole lives into this, but there are some issues that we need to talk about. Some people think sometimes I'm the predictor of doom. I do not mean to be that. I do know there are some hospitals in the state, though, where I walk through and everybody's like, oh God, who's she here to talk to today? But we're going to try and make this upbeat and talk about some of the issues that may come up in your own practice. Of course, we all know that we first do no harm. And so when we go back to the issue of patient safety, because that's why we're all here, that's what we do. Talk about patient safety. Every time you're seeing a patient, it's in the back of your mind. It's not in the forefront of your mind, it's in the back of your mind. And it's something that needs to stay in your back of your mind, which is why I think this topic is so relevant. I wanted to bring up, when we're going to be talking about aging physicians, but I wanted to bring up one happy thing. Interestingly, Dr. Peter Carmel, the AMA's immediate past president, is 75 years old. Pediatric neurosurgeon, probably a very complex, difficult specialty to be in. He said he's still going full tilt. We don't see that in all physicians, however. Let's talk a little bit about mandatory retirement, because I think that that is an issue that may come up. There are several professions that have mandatory retirements. We know airline pilots must start regular health screenings at a certain age and retire at age 65 from commercial. We have air traffic controllers, age 56, although they will make exceptions. Federal law enforcement, I thought this was interesting. I was surprised that it's so young. 57 or later if less than 20 years of service. They want to make sure they get their retirement years in. Then, if you talk about lawyers, we've got mandatory retirement for some judges, not lawyers, but judges on certain Supreme Courts. In certain states, it's age 70. Other states, Iowa, age 72. And then I wanted to compare and contrast. Don't forget, the Pope is there for life, but priests only age 70, and archbishops can stay for 75. I don't know why the difference. Never talked to anybody within the church about that particular issue, but I thought for our discussion today, it's interesting that for so many different professions, there are different ages where it is perceived, maybe for some unknown reason, maybe a good reason, may not be, that there's an age where there should be thinking about retirement. And I know that our Chief Justice, 2 Chief Justices ago, Chief Justice Lavarado in Iowa, he was very resistant actually to the 72 age. And I've talked to him about it several times, and he's very vocal about this, so I can say that. he doesn't think that it's a viable issue anymore because as people are younger at older ages now, which I agree with, he doesn't think that it should be necessary. But they've talked about it. They haven't changed it yet. It may be something that's changing. But as of now, there is still a mandatory retirement age, even for lawyers. So if we look at some of the studies, and there are several studies out there, I was surprised when I got started doing research for this speech. The reason that they come up with the 8,000 figure is a percentage of people over certain ages where they believe that there may be some sort of a cognitive impairment. One of the issues and one of the concerns, maybe not in a large system such as Mary Greeley or McFarland, but we worry about some of the physicians who are on their own. Maybe a rural physician, don't have anybody to bounce ideas off of. I know within our firm, we're talking quite a bit about retiring. Our head guy, Mr. Finley, is 73 years old, and he keeps talking about cutting back, yet he's in the office today, he's in the office every day. But we are actively talking about that because we know that it's not always the person who will recognize it first. It's someone around them, a loved one, a colleague. Yet what do we do if that physician is off practicing by themselves? First of all, we all know that doctors are terrible about going to the doctor. Well-known fact, doesn't matter who you are, it just happens. So if these physicians don't have a personal physician to go in and say, I'm just not quite as quick as I used to be, or I'm having these issues, what do you think? Well, that is an issue. It's an issue because you folks here in a larger center are getting referrals maybe from those smaller town physicians who may be working a little later in life. Some of them are fabulous. Some of them I would go to in a minute. But you need to keep open the idea in the back of your head when you're getting these referrals as to who is referring to you and whether or not age may be an issue. I don't know. One of the quotes I saw in one of these studies and I thought was interesting, I put down here at the bottom. It's harder to remediate people when it's harder for them to learn. We know people who have cognitive impairment have more difficulty sometimes learning new issues or learning new ideas. And I think we need to keep that in the back of our mind too. If we have that nagging suspicion that maybe there is a cognitive impairment in a physician that we're working with, a healthcare provider, that I think we need to maybe address. So that 8,000 figure a couple slides ago that we talked about, possibly physicians with cognitive impairment, comes from the fact that we know that right now there's about 850,000 physicians with active licenses in the United States. Then we look at the other numbers. How many are older than 50? How many are older than 60? And how many are actively practicing still older than 70? And we get these figures from the AMA. And so we keep those in mind when we're looking at physicians. These figures are from 2010. Didn't find the updated figures. But I can tell you, one of my partners does a lot of estate planning, retirement planning for physicians, and he says physicians are working longer. We know we had stock market problems a few years ago. We know that there's more extended families needing issues and concerns. Got a college kid who just came back home. So, we plan ahead for our retirement, but it doesn't always happen exactly as we had thought about and planned. So we know that physicians are no different than anyone else, and that we know that people are working longer now than maybe even 10 years ago. I thought this was interesting. I put this up here because this was actually addressed in several of the studies as a big issue, and I wouldn't have necessarily have brought this up otherwise. But they say that when we're talking about the gender, and we know in medical school now, it's pretty even, just like it is in law school as far as who's going to the schools. But they are finding that male physicians are generally less active than female physicians in the latter parts of their careers. And I think we all need to keep this in mind too. While we don't discriminate based on gender, we don't look at things based on solely on gender, I think it's something to keep in mind that as we move forward in the years, we may have been looking at potentially more male physicians who are getting older. We probably are going to see that shift as well, just like we saw it shift in medical school, several years ago now. So when we look at aging physicians, we have to look at some of the issues that will be concerned. One is, how do we detect those deficits? Well, as we started out saying, we talked about referrals in and people that you're working with. You do it just like you do your patients. Does this thought process make sense? Does the plan make sense? Are they getting on this quickly enough? May have absolutely nothing to do with their age, but it's certainly something we want to keep in mind. Remediation efforts. Is this person in a place where we could make remediation efforts? In other words, is this a physician who's in a large group? That then we can maybe have someone monitoring, even silently, for a while to see if this is even a true problem. It may not be. Are they in a small town maybe by themselves? Is that something different in our safety concerns as we come back to the ultimate issue of patient safety that we need to look at? Does administration in the health system need to know to determine whether or not there needs to be some additional remediation efforts or concerns or testing or any of those things? We all work within system here where there are people in place who can deal with that issue. We've got risk management. We've got medical staff, people, but not in all of those small towns in Iowa, which refer greatly into Mary Greeley because of where you guys are those things in place? And you need to kind of keep that in mind. The risk managers are well trained in how to deal with these issues in an appropriate sense. And so we need to make sure that the right people know about our concerns so they can be addressed. Then later on, we're going to talk about policy implications for a safe medical practice. Not only yours, but also the physician who may be at issue. Don't forget, medical malpractice cases are not going away. The numbers are not rising significantly right now. We know that, which is good, but they are staying there. They are not going away. And what we're finding in the medical malpractice world is if one physician on a case gets sued, a lot of physicians on a case get sued. You may be the physician who came in after the train wreck. You may be the physician who had no idea that these other labs were out there, which maybe would have caused need for additional hospitalization or testing or whatever. It doesn't matter. Your name's on the chart. So what we're seeing are that we're kind of seeing a scorched earth theory with plaintiffs' lawyers who sue doctors anymore, and they're saying, okay, we're suing everybody on and we'll sort it out later. I got dismissed from a lawsuit that I was supposed to try for a hospital a couple weeks ago, and I got dismissed on the Friday before the Monday the lawsuit was to go in front of the jury. So this hospital had been involved for 2 years. I've been trying to get out. I kept telling the plaintiff's attorney, you don't need me, you don't need my nurses. This isn't a nurse issue. But it takes them that long. The nurses have to go through the stress. The doctors have to go through the stress. If you're sued, till you get down the road where they determine maybe you weren't the person who was responsible for the medical care that they may have questioned, whether it's right or wrong. Do we consider part-time for aging physicians? Okay, well, we want everybody to keep their skills up. And you can't keep your skills up if you're not out there doing things in certain specialty areas. But there is some trend toward that in certain specialty areas that maybe that's a way to keep our aging physicians, who are, again, a fountain of knowledge sometimes. Some of our best monitors and mentors in the profession. Keep that relationship with the patients. But do we consider part-time? That's another thing that we need to talk about. A study done in September of 2000, well, published in September of 2006 on surgeons. And what they did is for, I think it was a year time, they went back and looked at 8 different surgical procedures. And they had Medicare, they had all the Medicare records, so they had over 450,000 surgical procedures in these 8 categories, which are shown up there. And then they collated those with the age of the surgeon. And it's the most comprehensive study that's been done so far on this particular issue. And to no great surprise, probably, they did find a statistical difference in the age of the surgeon for the more complex and lengthy surgeries as far as complication rates and outcomes. Again, I don't think it's hard to really see that. We know that certain specialty areas, the long surgeries, the neurosurgeons, the cardiac surgeons are sometimes saying, I can't even stand that long anymore. I mean, some of these surgeries that physicians are doing today, they weren't even contemplating, a few years ago, that they would go in and replace everybody's organs, that they would, these surgeries that are taking the 10 hours, the 12 hours, even the 8 hours, were not really contemplated several years ago. And so, we just didn't look at that particular issue. I think we do have to now. So as you can see here on the slide, it talks about those procedures that they did see a statistical difference, the pancreatectomy, this CABG, and the carotid endarterectomy. The other ones, they really didn't see a difference in the age of the surgeon. This is also coming from that particular study. One of the other things that they saw, and one of the things they were concerned about, were that the older surgeons were less likely to incorporate new treatment strategies into their practice. Well, again, some of the stuff seems very simple and makes sense when you say it. But as we always do our CMEs and our CEU hours to just remind ourselves of those things we know. I always say, I go back to, teenagers, they know the rules, but it doesn't hurt to remind them every once in a while because somehow they just forget those things they're supposed to know all the time. Makes sense. Less likely to incorporate new strategies. Absolutely. And I can tell you in medical malpractice case, again, we commonly will get the plaintiff's attorney. And when I say plaintiff's attorney, that's the patient's attorney. The patient's attorney will say to the surgeon in a deposition, well, have you read the new studies that show that this is the new treatment plan? They love to bring in that new state-of-the-art stuff. And we'll go back and we'll talk about it and we'll have our experts and we'll be ready. But it is something we hear frequently. Medications, how many millions of medications are there out there and coming out all the time? And now with the restrictions, maybe rightly so, about receiving information from drug reps, how do you keep up on all of the new medications depending upon when you got out of medical school and what your interests are? Some physicians keep up very well because they're just very interested in that particular area. And they put that time in to stay up to date. But that's what you want. You want your mechanic to stay up to date on the new vehicles, which need new treatment strategies. Same thing with surgeons. Poor performance on recertification examinations. I think this goes along with the other issues we talked about. Physician stamina, we've talked about that, and that's becoming a big issue. It didn't used to be in the medical malpractice cases. It is once again. We now are getting subpoenas to find out how long these surgeons have been in surgery that whole day. In other words, they're doing several procedures a day or maybe even only 2 procedures a day. Well, the patient's attorney wants to know what that other procedure is and how long they've been on their feet already. Did they get a break for lunch? Those types of things which we just didn't hear about before, and we are now, and it may be a valid question with some physicians. Then less likely to be able to communicate effectively. And I bolded that. That's my emphasis. And I did that because I wanted to remind myself to talk about a couple different things. People just communicate differently now. I go to seminars on how to speak to jurors. Because if we get younger jurors, they communicate differently. They accept communication differently now. I have to use PowerPoints in jury trials now. I use, all sorts of demonstratives. We have little mini movies. We got to keep things moving. When I first started, a lot of years ago, we just had paper and we'd hold it up in front of the jury. Or maybe we'd blow it up on a bigger piece of foam board and have a bigger one, to show the jury. That was the extent of it. Now, if you don't have a moving picture show in front of a jury, you've lost them. It's the same way with medicine. And so the communication has to be the same way. You have to understand your audience. Now, doctors have always had that, and I think, healthcare providers, whether you're a physician, a nurse, PA, whatever you are very intuitive people, or you wouldn't have gone into this profession. Absolutely true. Caring people, intuitive people. Well, it doesn't make any difference. When you're dealing with a different generation, you're going to communicate differently. The music's too loud. That was Elvis Presley. So we're moving on to different things now, and we need to understand that the older physicians probably do communicate differently. And within our healthcare system, whether it's Mary Greeley, whoever it is, you need to have the risk management people and the medical staff people understanding that they need to, every once in a while, look at that. Are we getting complaints about this physician? Well, is it just communication style or how they're communicating? Is that word getting across like we want it to get across to patients? I didn't know this, you guys probably all do because I'm not a healthcare person other than the MHA. 2 kinds of intelligence. Had no idea. Crystallized and fluid. And this is part of these studies too, and they talk a lot about this in these medical studies that I found on aging physicians. We've got the crystallized, which is cumulative information acquired throughout the life, includes professional expertise and wisdom. And the guys in the back with the gray hair, I'm going to point out, sitting in the back, by the way, they weren't sitting down here in front, it's just like school, sit in the back. They're our fountain of crystallized knowledge and intelligence. We're going to put that right there. I don't know your ages, but I do see a few gray hairs. I pay more for mine, so I'm not as old as you guys. There's also fluid intelligence, which is the capacity to process the information and reason, critical to analyzing and solving novel or complex problems. The fluid intelligence is what we're worried about. So I'm not dissing people who are over the age of 50. What we're saying is that the brain just works differently. And so we need to make sure that we keep that in mind when we're talking about or dealing with an aging physician who may be on the same case as you. Another study that I found in Academy of Medicine, 2002, so it's a little older, and I put the site to it on there so you can see it. And they did find that there was an issue in that fluid intelligence. And so what they do, the older physician will go back and rely on their experience. But again, remember, things change. Things change as far as what's state of the art and what's accepted in medicine. Medicines change over time. So you can't just rely on what you knew. You have to keep up with that other side, which is the fluid intelligence, not just the crystallized. Okay, so now there have actually been some studies done where there have been some physicians who've allowed themselves to be studied, who unfortunately they knew that there were some competency issues, and they do see these, what I see as a lot of communication issues, really. That first one, the prevalent errors of non-comprehensive history taking, that's a communication issue with the patient. You're just not communicating. Somebody isn't. It may be patient, maybe physician. But they do see this in these older physicians, some of them who have the problems. Incomplete data gathering and interpretation. I was telling Dr. Hallberg before we started, when I was a kid, I came from a small town, and I'd walk in, and my family physician, who lived at his office, of course, because he was, the guy who did everything for everybody, he'd be standing there by the front desk, and he'd be chewing on a cigar, which was acceptable in those days. And he'd say, "Well, what do you think's wrong with you? Come on back." But he knew me, and he knew everything about all of my family members. And so he knew what he could get away with and what he could do, and he knew my history. We just don't have that in this day and age. Deficient hypothesis generation, over-reliance on clinical first impressions. That was something they really discussed in this study, is that they were maybe a little quicker to say, oh, I know what's wrong here because I've seen this patient before, or I've seen this issue before. When we know that medicine is getting more and more complex with the different things that are going on and the medications that are there. So that over-reliance on the first impression, they saw more in these physicians who had the competency concerns. They weren't taking enough time, maybe. Okay, so we know that board certification is a way that we can test and make sure that everybody is keeping up to date on state-of-the-art, those types of things. Used to be that some of the specialties grandfathered in. I think that's pretty much just about, most people are older who have done that. But we worry about the amount of physicians. That's about a fourth of the physicians who are not certified or exempt from recertification. Now, a lot of hospitals require certification now to be on the medical staffs, but that's not true in the smaller areas again. So keep that in mind. What about the physicians who don't have hospital privileges? This is a kind of a new thing as well. Not talking about small towns here, talking about big towns. There's a lot of physicians in Des Moines who may have hospital privileges and may not, but they don't exercise them. They don't have anybody watching over them because there's hospitalists, there's intensivists, there's specialists who do that hospital work, which before, again, your family physician would follow you into the hospital, deal with you in the hospital, deal with you when you're out. We're not seeing that as much anymore. We are seeing in the hospital those specialists taking care of the patient. So if you've got a physician who doesn't have hospital privileges, maybe nobody is doing that double check or paying attention. I've seen this in a lot of cases too, where unfortunately I also deal with the Iowa Board of Medicine, and we'll get to that, but I've had some physicians who did retire felt like they were pushed into retirement. And we do see that from time to time, and maybe they weren't ready in their mind. Physicians, I think, more than any other profession, have their identity as a physician. Okay? I don't know why. It's great because that means that you're so entrenched in it and you want to help people so much that is your identity. But we see a lot of physicians who balk at the idea of retirement. Me, as soon as I can hit the beach, I'm there. But we don't see that necessarily in the healthcare professions as much. And so we see the physicians maybe balking a little bit more, and we need to keep that in mind too, that just because somebody doesn't retire doesn't mean that maybe they should start thinking about it. So how can we help ourselves? These are, I feel a little bad because some of these things I think make so much sense, but we want to go over them. We've seen all the things that we see with our patients when determining what might affect their cognitive status. I think the jury's still out on some of that issue. But I think that there's lots of things that we as a healthcare system can do to encourage some of these healthy lifestyles. Consider slowing down. Maybe that Dr. Carmel at the beginning, who's 75 and a pediatric neurosurgeon, maybe he can still do a lot of those things, but if I walked in with my kid and he's as old as my grandpa, I'd be a little concerned, about maybe what was going on. Provide longer appointments for patients with complex medical problems. I'm not here to solve the healthcare industry, sorry. I know we have a limited amount of time to see people. I know that reimbursement rates are down. But I think this is a consideration that we think about as a healthcare system. If I'm defending a lawsuit for somebody and that doctor comes in and tells the jury, you know what, I don't always spend 15 minutes with my patients. on certain things. If I know they're coming in for something more complex, I'll spend more time. We have a policy in our system that we're going to spend more time, or it's my policy, whatever. The jury's going to love that. And they're going to be saying, you know what, that physician has thought about it. I know some of you folks have heard me speak before, and so I'm really sorry if I'm saying this again. But Tom Finley, my big boss, has said that if we can show that healthcare provider is the 3 C's, caring, competent, and careful, we win every time in front of the jury. And I believe that's true. Caring, competent, and careful. So when you're writing your notes about your patients and you're talking about things, keep that in mind. Do you have a plan? That means you're careful. Do you have a plan in place? Did you notice them when they came in and make appropriate observations? One of the things I'm always preaching about is to write down if they bring some family member with them, because I'm going to want to know who's a witness later on. Sorry, but I look at it from the legal sense. But one way you can do that, when you walk into a hospital room and you see that there's someone sitting at their bedside, you say, "Oh, Mrs. Smith, who do you have with you here today?" Right away, that patient thinks you've taken a caring stance toward them because you want to know who's with them. Trust me, all you want to know is the first name. So you can go out and dictate, Mrs. Smith had Roger with her today. So you know who was in the room. But again, you are initiating with that patient and showing the caring side that you care about the people who are in there. And then I've got it for a lawsuit if I need to when they say, you know, my sister Sue was with me. And I'm like, actually, the doctor dictated that Roger was there. So it's one of those ways we can show that caring side. And then, of course, the competency, which is keeping up on the state of the art. I think that when we talk about this limited ability to self-assess, that is really one of my big concerns, and I think should be everybody's concern because, as we said, doctors are notorious for not going to the doctor themselves. So we need to make sure that we are thinking about that particular issue. Okay, now I looked at institutions, and actually there are a few that are starting to adopt policies for aging physicians. It's not widespread yet, but it's becoming more widespread. Stanford requires evaluation at age 75, and when they first implemented it a few years ago, several physicians just retired. And that's fine, that's their choice. Same thing happened at the University of Virginia. 28 of 35 older than 70 completed and passed easily the competency exam, but the other 7 just said, you know what, don't want to be here, I'm done. And maybe that's because they had those self-doubts. Maybe that's because they were self-assessing. Maybe they didn't want to go through testing, I don't know, but we're starting to see more and more facilities adopt these policies. A children's hospital in Corpus Christi, Texas, at age 70, they completed an exam, and the good news is in the first 2 years, 5 have completed and all have passed. So again, we're not saying that you're too old. We're just saying that we need to watch that like we would watch. We bring a new physician on board. Generally speaking, in most healthcare facilities, they're kind of on a mentoring, monitoring for the first year that they're there before they may receive full staff privileges. This is kind of what we're doing at the other end. It's the same thing. These are a couple of different quotes I took out of these different studies that were out there. I think that they just kind of remind us again that it's a good thing that you're healthy when you age. You can do a lot of really good things for patients. If I can go see somebody who looks like a Marcus Welby, I'm going to, just because I feel more comfortable, because Marcus Welby is supposed to be the standard, for everybody. But we do have to understand that there are some issues. And when you're looking at aging physicians within the healthcare facility, these are kind of some of the things you'll look at when you're determining if you've got a physician who's referring into you, say, and you're like, you know what, I know he doesn't get out of the house much, or she doesn't get out of the house much. You might be a little more worried about that person, right? Or the physician who doesn't want to take on the EMR. I know we all have to now, but if they're hesitant to do that, that might be somebody that you might be a little more concerned with or are talking about. Okay, liabilities. Oops. Physicians have liabilities like other groups. We know that they put too much into what they're doing as a physician. They may not have a diversified life. You got to have a wide range in your life. We're always teaching people, to make sure that they keep healthy in a lot of different things. But we know that physicians as a group are not all that good about that. So, if you have to evaluate a physician, an aging physician, these are the things that were looked at in those studies. They went back and looked at their performance in medical school, whether or not they're in solo practice, hospital privileges, so somebody else is interacting with them. I know in my practice, I can't even imagine practicing by myself, but there's a lot of lawyers who do it. Because I'm forever in somebody else's office saying, okay, I got this issue. What do you think about this? Or, did you hear about this new case? Are you interpreting it the same way I am? We know that the collegial atmosphere and working together helps everybody. Board certification we talked about. Sometimes, unfortunately, we see people getting a little outside maybe where they should be going. And I think that's another factor of maybe somebody who's not self-assessing well as to where they should be and what their limitations are. Burnout, we can start to see in people. Organizational and system problems, those people who are not interacting well maybe with the EMR system, because that's what ultimately I have to take into court if there is a medical malpractice case. I say those medical records are my Bible. I take it in front of the jury, and that's what we live and die by. And if you're just checking the boxes on EMR and you're not doing any narrative because you don't like to type, that's not helpful. It's not helpful. We also see these things, unfortunately, in aging people. Don't have to do with physicians, but in people who age. I want to talk about a couple other studies here. There was actually a study done in Quebec, and it was over a 10-year period. They contacted these physicians ahead of time and said, we're going to come in and we're going to look. Now, it's Canada, so they can come in. They can force you to do everything. As far as your physicians, it's all this healthcare system. And they rated each physician on 0, very good, to 4, which is cancellation of their federal Canada healthcare insurance, malpractice insurance. And what they found, unfortunately, was that physicians over the age of 70 had 3 times the rate of that 4, which is cancellation. And then physician ages 65 to 69 were twice as likely to require either a refresher course in an area or a limitation of practice. This is also a new study that was just published. Another study, and believe it or not, this is in Canada as well, where they came in and looked at different issues, and they also found deficiencies, a higher percentage, because we start with 22% over 75 had gross deficiencies, 16% of the ages 50 to 74, and only 9% under 49. So we are seeing studies out there that do tell us that there is empirical data that supports this potential concern for the aging physician. It brings it all right back to the Iowa Board of Medicine, who licenses every physician in this state. I put up there their definition of impairment. And I can tell you, the Iowa Board of Medicine is not easy to deal with. You get in the sights of the Iowa Board of Medicine, and they've got their sights on you. Do not forget, when the Iowa Board of Medicine calls you or comes to see you, they will flash a badge. I've seen them go back to the recovery area to find a surgeon. They'll just bust in and say, I have to talk to them right now. You do not have to talk to them that very instant. You absolutely have to cooperate, and you should. But why would you stop what you're doing to do something completely different? It takes you out of your train of thought. So that's why I counsel my clients not to do that. You just say, you know what? Love to talk to you. Let's set a time, just like you would for a patient, so you can review the chart. If they catch you off guard, who knows what's going to come out of your mouth? You haven't looked at the patient chart, because they may be asking you about a specific patient. You haven't looked at that chart recently, and you are concerned because it's the Iowa Board of Medicine and they hold your license. Don't talk to them right then. Really, talk to the right people, whether it's risk management, whether it's a supervisor, whether it's a colleague. Either get to legal counsel so you can talk these issues over, because the Iowa Board of Medicine can take your license. And they do have a definition of what they call impairment. Why is this important? Because there is a Rat-Fink rule at the Iowa Board of Medicine. A report shall be filed with the board when a licensee has acknowledged that another person licensed may have engaged in reportable conduct. Reportable conduct is an impaired physician. So you know that there's another physician who may have some cognitive problems that may be affecting their practice. Do you have to run right away and call the Iowa Board of Medicine? No, please don't. But you do have to go through the process of thinking about it and going through the appropriate people in the hospital, administration, or your clinic system. Because what they'll do then is get a hold of legal counsel and we'll talk it over. And that will relieve you of some of that burden. Ultimately, the burden's yours because you hold the license. But we can talk it over and determine whether that's an appropriate thing to do at this time. Okay? But know that that rule is out there, and the Iowa Board of Medicine has, in fact, sanctioned physicians for not reporting other physicians. Generally speaking, I've not seen one on an aging physician, but I have seen it where, say, a physician has an impairment because of alcohol or substance abuse, and their partner knew, and they were trying to kind of get them into therapy and things, and they have done that. But understand, again, you don't have to run right away just because of your suspicions, even though that rule is in there. You need to go through the process and talk to the right people who can deal with legal counsel and determine what your responsibility is. That helps you later on. Because let's say the Iowa Board of Medicine investigator comes out and says, why didn't you call us and tell us? You can say, I spoke with legal counsel, I spoke with administration, and ultimately the decision was made. So that helps you if you go through the right channels. Oops, wrong one. Okay, the board can order a physical, mental, or clinical competency evaluation. So you don't have to take on that burden. Say you do believe that there's a possible physician with competency issues. The board can order that if you get down the road and it is determined that there needs to be a report made, and they will do that. Now, as a healthcare provider, if the board actually gives you one of these, and it'll be confidential, you'll get something that's restricted mail to you that says you need to go through a clinical evaluation, call your legal counsel right away, but also understand that you probably have to do it. There's no way really out of it, quite frankly. There are ways to talk about it ahead of time, but I have to tell you, the board has won that fight at the Iowa Supreme Court a couple of different times where we've tried to say there's no reason for this evaluation, but the board will probably win on that. I found some statistics in New York where they showed that all enforcement actions by their licensing board, 40% were over the age of 60. Now let's talk about Iowa. I just went back and counted the last few press releases, so you can see I only went back 5 or 6 months. And I was surprised to find the ages on there as far as how many of those physicians with these disciplinary actions were sanctioned. There were a total of 10 reports of discipline on 9/5 of 13, so a total of 10 physicians in the state. 40% were over the age of 65. In July, 14 reports, 50% over the age of 60. Only one report in June, and he was 77. 2 reports total in May, one was 71. In April, only 1 report, and he was 65. So is this a real issue? Maybe. Certainly means that we need to talk about it. Means that we need to deal with this issue. Do I think the Iowa Board is maybe a little harder on older physicians? Maybe. But it is what it is. It's what we got to deal with. So understand that this is a real issue. While, again, we may think this may be something that may happen in the future, if you get in the sights of the Iowa Board, they more often discipline those older, aged physicians for whatever reason. A whole bunch of different reasons for these disciplines. But I just went back and counted so you could see what Iowa was doing. That's the end of it. I'm happy to take any questions you may have. It's almost 1. I know that we wanted to get out of here because you got patients to see, which is much more important. But I thank you for your attention, and I'm happy to take any questions you may have.
What the problems might you see with maintaining a license when a person is retired and no longer in active practice?
Actually, it's not. You can, as long as you keep up your CMEs, you're okay. So are you talking about maintaining an active practice or just maintaining your license?
No, the license.
The license. It's not. They want you to pay your money and they want you to do your CMEs and they don't care. So if for you as a physician you want to maintain that license and keep it, the Iowa board's not concerned about that. They just want to make sure you're keeping up on your CME requirements.
How do you get away from age discrimination when you say automatically at age whatever 65 you have to be tested? The last time you talked with us, we can't set ages for testing. So you're a lawyer, we need attorneys.
Different on safety issues, that's why. Age discrimination is a real issue. However, when safety is an issue, which is why they can get away with it with air traffic controllers and pilots and FBI agents and those, it's because there's a safety issue that overrides that mere age issue. So you're not picking on them just because of their age. You're picking on them because there are studies out there that show that age may be a factor for patient safety.
It's also a young age, too. The first year out of surgery training, you haven't done, I mean, it doesn't make sense.
Oh,
to
I
me
think it's more than 1 year, particularly in the specialty areas. I don't want to go into somebody who's younger than me. I get in there and we see Doogie Howser, and that scares us as much as maybe the physician who can't get around without a walker. I agree with you.
Well, so I don't know the answer to your question. You've just said we can automatically make, well, let me change it this way. Can you make differences for surgeons versus pediatricians? I.e., all surgeons can't work beyond age 60 unless they've had a competency test established by whom? I mean, I think you've raised more problems than you've helped.
You know what? That's what lawyers do. We don't mean to.
I know you do. You make money doing that.
That's what we do. That's why nobody wants to see me walking down the hallways of the hospital.
Yeah.
I have not seen any studies that have not discriminated, but distinguished between the specialty areas. Because that might be a little bit more of a problem. But it is absolutely true that you can start requiring testing of some sort at some age now in the United States.
So we can...
You can. You just have to put the right policies in place, but absolutely. Because, again, we now have the studies which show that age is a factor.
All right. Sure it is. I mean, in everything, cooking and sleeping and
yeah.
I think it's a problem. What
and
I'm
driving
trying to say.
And
I've been there where we have used your guidelines, established an age, and got in trouble. So.
Oh well.
And with legal advisement too.
It depends
so
on what
you
your
be
reason
careful.
was for it. You do always have to be careful.
Be careful, everybody.
It doesn't stop anybody from suing. That's the whole thing. Just like if you give 120% patient care, quality patient care, doesn't mean the patient isn't going to sue you, because that's what people do these days. We just try and go through the process as best we can.
By the way, a great talk. Thank you.
Oh, no, that's fine. Nobody ever likes me either. I'm a really nice person. And when I grew up, nobody in my family were lawyers, and I lived in a small town. In fact, so small we had to go get our mailbox. We had to go get our mail uptown. They didn't deliver it. And so when I went in one day after college, the postmaster, who'd known me since I was born, said, "Connie, what are you going to do?" I said, "I'm going to law school." He said, "Oh, you were so nice." That's what he said. And I was like, what? He was dead serious. So
the bylaws committee here, every 2 years for probably the last 8 years, have had this discussion. And the committee has always felt that an age number was just arbitrary, because
and I think that's probably true.
You can have the competency issues at a much earlier age, and so we've stuck with kind of the peer evaluation and the ongoing...
Wait until there's a complaint or a concern.
Yeah, well, but also the peer evaluation, that where peers might know more that is showing up maybe in an office setting and not in the hospital setting, or vice versa. So we've kind of looked at that, but my question I have for you is, are you seeing that become much more detailed in the peer evaluations and the referencing?
No, I haven't.
Kind of the more detail in the questions, or?
Yeah, I have not seen age as an issue. I was surprised to see that Stanford, University of Virginia, those large centers are really into this issue. But I think one of the things I really wanted to stress today, and one of the things I think that you've brought up and was very important is that within this hospital, you do have peers who are not watching you, but who understand your practice and your practice, how you deal with things. But the people who are referring into you folks here may not have that advantage. And so I think you have to keep that in your mind as you're dealing with a patient that comes in from the outside, maybe from a smaller town with an aging physician who may or may not have been, I had a case not too long ago where somebody was treating a patient with high levels of steroids for like 5 years, and you're just like, okay, we don't necessarily look at that. It was an older physician who just had not gone through maybe some of those newer MS protocols.
Right. And I get that. That's saying that we have to be very sure that when the accepting physician is doing a very complete history and physical examination.
Right.
And if they're doing that, then they're finding that information. We don't, per se, as a hospital, don't have a responsibility for those that are referring into us.
No.
And so what I was looking at is from the physicians that we credential and reprivilege every year, are you seeing more depth in the type of evaluations from the peer references or the other facilities that go into the impairment question or impairment definition from the Iowa Board of Medicine?
Yeah, that's a good question. I'm sorry I didn't get it the first time. Well, that goes back to the fact it's the Cawthorn case in the state of Iowa, but it never used to be an actual cause of action for a lawsuit, negligent credentialing. It is now. Negligent credentialing is recognized as a separate lawsuit or cause of action in the state of Iowa against a hospital who did not take action based upon information they knew or should have known about a physician on their staff. So yes, we are seeing that, and it's something that I think hospitals need to address more thoroughly because they're going to be asked about it if there is a lawsuit later on. Well, why didn't you look into this issue? So yeah. That was just 3 years ago that negligent credentialing was first recognized in the state of Iowa. We'd never had it before. Thanks for your time, folks. Appreciate it.